Welcome to Muted in Medicine, the podcast where we break the silence on the untold stories and pressing issues within the healthcare profession. Join us as we dive deep into topics that often linger in the shadows of medical corridors and are not discussed in conferences, meetings, social gatherings, and in the hallways. They are often hiding. From navigating errors and facing litigation to the often overlooked realm of mental health among healthcare professionals. Through candid conversations and storytelling, we aim to amplify the voices and shed light on challenges that resonate across the medical landscape. So grab your stethoscope and a cup of coffee and tune in as we uncover the layers of complexity in the world of healthcare that are so muted yet so profoundly impactful. Hello, everyone, and welcome to our first episode of Muted in Medicine podcast. I'm very excited that you have decided to join us today. My name is Saba Fatima, and I'm currently a practicing pediatric hospitalist. This podcast was started because of the need that I felt going through a traumatic event at work in healthcare, like an unexpected outcome in a patient, imposter syndrome, being a new attending, grief, a microaggression at work, and not having a safe space to have those discussions, and hence feeling alone in that process. I have had many conversations behind closed doors with my family, my friends, and my therapist on these topics, but not many of these conversations are out in the open. And the goal of this podcast has to have these conversations for our audience out in the open. So if they're feeling alone after something terrible that happened at work in healthcare, which we all know does happen, they can tune in. And so I will be inviting my friends here to have these various conversations. I would like to start this podcast with this quote: "Doctors are horribly alone. The doctor's world is one where our own feelings, particularly those of pain and hurt, are not easily expressed. There's a silent but terrible collusion to cover up pain, to cover up depression. There is fear of blushing, a machismo that destroys us." Our first guest today is Dr. Ali Rafiq. He is a practicing internal medicine hospitalist in Kansas, and today we will be talking about medical errors. Ali is really passionate about making healthcare systems more safe so that errors don't happen. And I'm very passionate about creating support systems for providers when such events do happen. And so together, we'll try to talk about both aspects of a medical error. Dr. Rafiq, welcome to the show.
Thank you.
So we're going to start off by asking a question that we like to ask everyone who comes to our podcast. Obviously, you're the first guest. But tell us something that gives you joy in medicine today.
Wow, you're starting off with a loaded question, and it implies that I get joy in medicine, but I do. And the basics remain the same regardless of how long you're practicing. As a full-time clinician, the primary joy comes from giving hope and healing to your patients. As you mentioned, I practice as a hospitalist, which means that all of my working hours are spent in the hospital. And the hospital, as you know, when someone walks in as a patient, they're not really feeling their best at times. They're pretty close to dying. They're in a very vulnerable position in their lives. Their family is in a very difficult position as well. So just to play a little role in making them feel better in a way that by the time they walk out, they're feeling a lot better than when they came in, really is the primary source of joy. And then, of course, there are other things as well, like the camaraderie that I have with my peers, with my colleagues, the meme battles that we have on our joint groups, and just the overall feeling of support that we have in the community. All these little things really bring joy every day and makes me keep going to the hospital, moving forward.
Yeah, that's very cool. I'm very intrigued about those meme battles that you talked about. Hopefully, you'll fill us in later. But just getting back to the topic, So, we're talking about medical errors today. I know you're very interested in creating safe systems so that medical errors don't happen. Just starting off with the basics first. How common are medical errors? And if you can just start with the definition, what is a medical error?
Yeah, so medical error is a pretty kind of an umbrella term. It can mean different things in different situations. I think there was at least one study that suggested that around 400,000 medical errors happen every year in the United States, which is a humongous number, leading to a lot of mortality and morbidity amongst the patients that are hospitalized in the inpatient setting. But overall, like looking at medical errors, as I said, it's like an umbrella term. So there are different categories and different definitions that you can think of. One way to start, a starting point can be an adverse event happening in the care of a patient. All right. So if that adverse event is what's a known complication, for example, a patient with MRSA pneumonia being treated with IV vancomycin, all right, IV vancomycin, you can have kidney injury. So if there's a kidney injury that happens because you're treating a patient with IV vancomycin, that wouldn't necessarily be called a medical error, although for some people, they might feel that okay, an error happened in that situation, but that would be kind of more known complication. But let's see something is not a known complication and something bad happens, or rather, something happens that is not in line with what's considered to be standards of care. In those situations, you would categorize that as a safety event. All right. And then once you go down the safety event route, then you can have, okay, well, the safety event happened, which was a deviation from standard of care. Did this safety event cause harm to the patient, or did it not cause a harm to the patient? If it caused harm to a patient, then you can start going down. Okay, was there an error? Was there a personal error involved? Was a systemic error involved? And if no harm was done, it's still a safety event, so it could still be categorized as a medical error. But in kind of the world of patient safety, you would call that more as a near miss. But I think classically, when we're talking to clinicians, when we're talking to in general conversations, the main medical error that comes to our mind is, okay, something deviated from the standard of care, hence it was a safety event, hence harm happened to the patient. And most commonly in these conversations, the harm is of a severe nature. For example, leading to a patient's death, or a procedure which they didn't need, or an extended hospitalization. So I believe in most conversations when we're having with clinicians about medical errors, that category of medical errors is kind of what is brought to the table.
Interesting. That's very helpful. I guess so. The thing that I would like to know is how do these medical errors happen? So I think we know that healthcare providers are sometimes at the forefront of it because they're taking care of the patients. And so do medical errors happen due to an individual's mistake, or there's a broader scheme of things that is going on in the background?
Yeah, so that's a great question. I think it's important to realize that the vast majority of medical errors are most likely because of systemic errors, right? There's some error in the system that leads to harm reaching the patient. In the patient safety world, they often talk about the Swiss cheese model, right? In which you kind of imagine, a block of Swiss cheese that has holes in it, and from the event of that event happening to the harm, there are a lot of systems in place within a mature hospital system to prevent that error from happening. But unfortunately, in some cases, that event ends up passing through all those barriers, going through those holes in the Swiss cheese, and harm actually ends up happening to the patient. There are lots of different kinds of medical errors. As I said, most commonly they're systemic in nature, but they can happen in terms of medication dosing or medication administration. And there could be diagnostic errors that can happen. There could be procedural errors that can happen as well. And any mature hospital system would have certain barriers that would try to mitigate those errors. Edwards Deming, the famous Edwards Deming once said, any system is perfectly designed to deliver the results that it delivers. So kind of the whole idea behind that is that if errors do tend to happen in the system, there should be ways of trying to mitigate those errors. And that's what makes me really passionate about patient safety and quality in general, because every error that happens is an opportunity to work on a systemic level to prevent that error from happening for another patient moving forward.
Sure. And I think you brought up a great point about how medical errors are most often because of imperfect systems, and not clearly imperfect individuals. However, we are imperfect as individuals and humans, but I think it's important to emphasize how systems are involved in medical errors. I guess moving on just a little bit to something that I am deeply passionate and interested in. Um, and we talked about how healthcare workers are at the forefront of an error most of the times in hospitals, how, or in clinics or outpatient settings or in emergency departments. How does the medical error impact the physician or the nurse or the pharmacist or whoever, I would say, or was involved in the process of an error?
Yeah. I mean, the impact is huge, and you've done your own, research on the emotional burden that happens in the setting of medical errors. Because as clinicians or anyone involved in the healthcare setting, by the time you get to a point where you're taking care of patients individually, you've already gone through years, perhaps even decades of education and training and taking tests and examinations. So in general, people who are involved in care of patients, particularly at the bedside, put themselves at a very high standard, right? Perfectionism is sort of it's almost standard in the healthcare setting. So when errors do happen, it takes a big emotional toll on whoever's involved in that forefront. Although that person themselves might just be a small part of that huge systemic lapse that happened in that particular unfortunate situation. But there can be feelings of fear, of shame, of guilt. It can lead people to depression, to anxiety. It can affect their personal lives as well. um, and if it's severe in nature, and if someone does not have enough resources to deal with it, then it can just have a lasting impact and on their overall emotional well-being as well. And that's where conversations like this really help in talking to people who've been through this, because as the title of your podcast is, muted in medicine, a lot of these things people don't really talk about, because again, with this comes feelings of fear and shame and guilt. And it's almost like if it's a room of 10 people and everyone has suffered in this way, but no one's talking about it, they end up feeling like they're the only one. So these conversations really help with the discourse, help with the discussion, and help ease some of these feelings of fear, shame, guilt, depression, anxiety that someone might face when they're at the forefront of a medical error from happening.
Yeah, absolutely. And I agree. I think when you said that a lot of medical professionals obviously go through it and are involved in a medical error or have seen somebody who's involved in a medical error or has been involved in a near miss event, but still there is a lot of guilt and shame associated with it, as you so rightly mentioned. In fact, and our listeners might already know about it, there is a term that has been coined for this very trauma that caregivers suffer. It was described by Dr. Albert Wu over at Johns Hopkins, and it was called a second victim phenomena, and it is described as the suffering of caregivers in the face of a medical error. And they've done a bunch of studies on it, and almost 50% of providers suffer this in their lifetime. And a lot of times, like you said, I think it's happening to us, and we don't really know what's happening because we haven't heard about it or we haven't talked about it, and so we don't have a word to it. And sometimes we just go through it, and later on we find out that it's actually a very real phenomenon and happens to a lot of healthcare individuals as well. In second victim, I think some of the things that I've seen happening to healthcare individuals, and it has been studied. So it's very interesting because they've actually studied what a healthcare provider can go through, like what stages. Um, And the first one, whenever you have involved in a medical error, is chaos, because you feel like, what happened? Why did it happen? How could this have happened? Here this patient was fine, and this big mistake happened, or an unexpected outcome happened. So there's a stage of chaos. And then there's a period of something called intrusive reflections, where healthcare providers are worried about the details of the case. So, for example, talking about giving the wrong dose of medication, like how did it really happen? They will go through all the fine details and see how could it really have happened. Like they revise it over and over again in their head. And then there's a third stage when providers start worrying about personal integrity. What if Dr. Rafiq finds out? What if my colleagues find out? What if the board, the licensing board, finds out? And then the final two stages are, first, physicians or healthcare workers finally start looking for emotional first aid and a lot of help from people around them. They need a lot of professional reassurance. Sometimes they need counseling. And then finally, the last stage is moving on. So either some healthcare providers thrive, some survive. Survive just meaning they're still working in healthcare, but they have intermittent reminders about what happened internally. Um, and some drop out, they decide to do something else. So, just important to mention here while we're talking about how we can improve these systems, of how it really impacts the physician. So, if someone is listening and if they're going through any of these stages, they know that it's well studied, it's out there. You're not alone. I guess that's the one thing I'm going to say. You're not alone. Um, Getting back to hospitals and systems, when an error happens, how do hospitals respond, and how can hospitals respond more justly? Um, is there usually punishment for the physicians involved, or is it more of just like a self punishment because physicians feel so much shame?
Yeah, so that's a great question. So any mature hospital system should have different mechanisms of looking into these safety events or errors that happen, and there are like different layers to it, right? If a patient dies unexpectedly, in the very granular level, we look at the numbers, we look at what their expected mortality was, and what the observed mortality would, of course, be one if a patient has died. But if the expected mortality was really low, then that stands out. So they can have like mortality review committees that can sit and look at those particular cases, and see if how things could have been better from a system standpoint. And if there appears to be an obvious lapse from a clinician, like a physician, uh, then there's the other whole branch in which it's called peer review. All right, so that particular case goes to peer review, in which fellow physicians can look at the whole situation and basically try to determine if standard of care was met or not met. But of course, not every patient who suffers from harm or medical error dies. So in those situations, you can have other, safety event or medical error review teams that looks at the same process essentially, perhaps do a root cause analysis, try to go back and see in every step of the way where they can find out where the lapse in that Swiss cheese model happened, and try to figure out the systemic issue behind it. And if they think that the system did what it had to do and it was perhaps an individual thing, then again it can go to peer review. If it was a physician, if it was a nurse, it could go to like nursing review and things like that. And if someone's listening to this and their hospital does not have this kind of a system, you can champion the system, right? That's where the opportunity is. That's where you can be passionate about patient safety. That, okay, there isn't a system over here that looks at this in a fair way. Maybe you can be the one who can champion it. And there are like multiple resources available to help you do that at your institution. So that's the hospital standpoint. Um, the other important thing is, you might have mentioned what's called just culture. All right. So just culture is sort of an overall culture of an organization in which we understand that, okay, errors happen. Errors take a big toll on the patient and their families and the emotional well-being of the care providers as well. But most errors happen due to systemic lapses, due to lapses in the system. And perhaps there needs to be open conversation and open systems over there to try to fix these errors, fix the systematic issue that led it to the first place, instead of pointing fingers and blaming individuals for it. Because what happens when you just blame individuals, when you just, I mean, of course, there can be exceptions to this. There could be, individuals that are suffering from something, and that's like a different route. But that's not really the vast majority of the cases. The vast majority of the cases, as I mentioned, occurs because of systemic errors. So in a just culture, the organization would acknowledge that, and it would encourage its people, the people working in the organizations, to be partners in helping improve the system overall. Um, in a just culture, people would be encouraged to report medical errors because they know that okay, most errors are because of systemic issues. This event happened with this patient. I don't want this event to happen with patients that I'm going to see for the next 10 years. Let's try to fix it. Let's try to report it. And then the relevant people would sit together, perhaps talk to you, and try to fix this systemic issue from happening and affecting patients down the line. So that's kind of what the overall umbrella of just culture would look like, in which people, sort of the foot soldiers, the people involved with the bedside care, are encouraged to report these events because they know that they're part of the system. They know that they're team players in that review team. They know that through this action of reporting, um, the care that you're providing to hundreds, perhaps even thousands of patients down the line can potentially improve, can save lives, can improve morbidity and mortality. And that's the kind of culture that should be encouraged in healthcare systems all around.
Yeah, perfect. Absolutely. Thank you for mentioning the just culture, because I think just culture is also beneficial to the physician or the healthcare worker that has made the error as well. Because I guess it means that they're not punished without cause or without obvious recklessness. Um, I think 95% of errors that are happen by healthcare providers, they don't do anything intentionally, so they are human errors. And in that case, when any peer review committee or anybody looks at it, the individual per se should not be punished for it. But for example, if I was a physician who had gone through a medical error, just taking it as an example, and as we talked about, there's worry about peer review, and you talked about all these things that could happen in the aftermath. How do I, as a physician, can navigate the worry, I guess, associated with it, and how would I expect the hospital to respond? Like when a peer review happens, do I expect to be punished for that? Or how worried should I be about litigation, about peer review, and how can I prepare myself for it?
Yeah, so litigation is like a completely different branch, right? So, we can talk about that too, but from a peer review standpoint, I think it's important to realize and understand that if your organization just does have like a just culture, peer review is just part of the process. We're all in it together. We all want to deliver the best possible care for our patients. Maybe something happened for a patient that deviated, or you know potentially deviated from what would be considered standard of care, and hence there's just this system which is there to look at it, perhaps get your perspective as well, to see how things can get better moving forward. You mentioned the word recklessness, and sure, personal accountability is very important. I'm not saying that people are, personal accountability, we can just say, okay, you're not personally accountable for your own actions. So I mean, if there has been a pattern, a consistent pattern of recklessness from one particular person, then there are systems to kind of address that as well. Sit down with the person, try to figure out what the root cause of that is. Is there a gap in knowledge? Is there something else that's going on, and try to address that? But I think in general, clinicians should not be fearful of something going into peer review, because again, that's just part of the process. That's just the system trying to figure out, okay, you know what, this adverse event happened. It was odd because it appeared to deviate from the standard of care. Let's sit and look at it and try to figure it out. And it might not be the case that it perhaps did not deviate from standard of care, and that was just perhaps a known complication of a procedure or medication or something like that. But I think the main thing I would say is if clinicians start seeing themselves as partners to the healthcare organization, as partners to the patient safety department, as partners to the whole ecosystem of trying to make things better for the care delivery to the patients, I think that would help um, alleviate some of the fear and anxiety that comes when something like this happens. And then I would always encourage, be part of the system, be part of those safety event teams, be part of those mortality teams, be part of the patient safety department as well. Because I think at the end of the day, it just helps us become better care providers for our patients. Because if you're providing care, of course, you're providing individual care, you have your own experience, you have your own training, but becoming a part of those systems just helps you enhance the kind of care you're delivering as well, because it helps you look at things from a more broader perspective. It just broadens your horizons instead of just sticking to your own training and your own experience. So yeah, to answer your question, I think if medical errors are bound to happen, right? Because we are imperfect as humans, we are imperfect individuals. We're not perfect.
Sure.
So to expect perfect outcomes when the input is imperfect is a little unrealistic. And that's where I feel, systems need to be designed in a way in which those imperfections can be mitigated in the best possible way. The EMRs play a big part in that, right? I mean,
Mm-hmm.
Ordering a medication, two medications that sound pretty much the same, but they're written differently in the EMR just so that your brain does not overlook that. That's a smart thing that the system has to mitigate that error, right? If you're ordering a medication that needs to be dosed differently based on their kidney function, and the EMR pops up and says, "Hey, you know what? You're ordering this dose. You can still order it if you want. It's your decision at the end of the day. But this is what the creatinine clearance of the patient is. So maybe you want to redose it. So that's smart. That's the EMR playing into and helping you mitigate that risk, right? So I think the more you can be involved in that process, the better grasp you get of the system in general, and helps you become a better care provider at the bedside for your patients. But in case something does happen in which it goes to peer review and it goes to all these processes, I know it can make you anxious, can make you fearful, can give you shame as well, but it's just part of the process. Mature healthcare organizations need to do that to help, the care that they deliver to their patients at the end of the day.
Yeah. And I think it's very important just to think about that in that perspective, using an error as an opportunity to learn and not as a
Mhm.
personal failure, and see how we can make the care of the next patient better. I think if systems, if hospitals and everyone starts to look at it that way, then we can create more psychological safety for providers actually to report the errors too, because that's how better patient care happens. Because I do know that a lot of providers feel fearful to report errors if something has happened. Um, and I guess, do you have any suggestions on how we can improve that?
Yeah, so that's a very important question. And I think just having some resources is very important. Having some kind of a peer support group is very important. A lot of, big healthcare organizations offer tools for well-being as well. And having some safe space for discussions, just like you're doing over here, is very important as well. Um, and there's so many different resources. Like, for example, I know one of the healthcare organizations introduced this idea called a battle buddy, in which you're kind of paired with this one other person within your group, and if something bad happens, you can always talk to them and they can talk to you. So having that kind of a structure, of a system, it can actually make a world of a difference for someone who goes through something like this. Because as I said before, it's not a matter of if, it's a matter of when. Something bad will happen because we are operating in extremely complex environments. The human body is complex. The disease gets more and more complex as we move forward. You're seeing a bunch of different patients with different pathologies. It's a matter of when. And when that happens, it's important to have resources available, to help clinicians with that. Because if there aren't, eventually it can get the better of you, right? I mean, we've talked about, a lot of people have talked about moral injury and burnout, and it's becoming such a big thing in US healthcare. You want clinicians who are in the right frame of mind, who are motivated to take care of patients coming in every day. You don't want a morally injured healthcare force. You don't want a morally injured, you know, uh, set of people working in an organization. So it's important for organizations to be proactive about this and know that, okay, again, it's a matter of when, it's not a matter of if. And when it happens, there are adequate resources available for these clinicians to seek and help them deal with these feelings of fear, shame, guilt, anxiety, depression. That's going to help them bounce back and take care of the next patient in the best possible way to the best of their ability.
Yeah, and just piggybacking onto that, I think most physicians or providers in the aftermath of an error is what they need is just consolation and moral support. And some might not want it actually because they're more private and they don't want it. But I think it should always be an opportunity for them to get that if they need it. And as you mentioned, there are in a lot of healthcare systems, there are like you have a rapid response system for when a patient is clinically deteriorating. They also have kind of a rapid response system for when a healthcare worker needs help or when a traumatic event like that happens, and peer support system that you talked about. And I almost believe that it should be standard of care across all hospitals for that to be present. Um, because it's such a, I would use the word, it's such a hard discussion for us as perfectionists to talk about an error that we made, that the more we normalize it, the more we talk about it, is the more people will be willing to seek help. And I think the help should be offered every time such a thing happens, and they may or may not take it. Um, just talking about what healthcare providers need when something like this happens. I think as an individual, like if you had a friend or a colleague who you know is suffering from this, I would just say they need some sort of emotional first aid, like support, reassurance, sometimes professional reassurance. Just they lose their confidence when something like this happens. So just telling them that they are good doctors or they are good nurses and that you have witnessed that, I think just a little bit of that helps. Just being there for them and listening in a non-judgmental way helps. And I think not saying things like you should quit. I think that's the worst thing that you can do, that you're not cut out for this, you should quit. Because sometimes I think when people around us see that we're distressed, they tend to say those things. But just to help, like we talked about earlier, to use it as a learning opportunity. And I mean, it does get better with time. And a lot of physicians also like rationalizing it and making sense of what happened. So once you do that, it does get better with time. But in the immediate instance of the event, most of us need consolation, and then eventually we can look at why it happened and do coaching and all those things to prevent it from happening again. So I do believe that this should be universal across all hospital systems, and it should not be a choice. Just moving on to another stressful thing that could happen after an error, which is litigation. And we might talk about that in detail in another podcast. But once you have made an error, how do you deal with the risk of litigation? And just what do you feel about criminalizing healthcare professionals who've made an error? Since we've talked in detail now that these are imperfect systems.
Yeah, and again, that's like a whole sort of a different tangent on how to like deal with litigation. And again, another muted topic in medicine that we don't really talk enough about, and there's like so much. It's kind of the elephant in the room
Hmm.
that no one really sees, right? It's almost kind of the back of everyone's mind when they're walking into a patient's room. Just don't do something that will get you sued. Um,
Yeah, that's why it's called
and
muted in medicine.
right, right. So I think it's just very state dependent because litigation laws, malpractice litigation has different laws in every state. So I think the first step is knowing what your state laws are in terms of litigation, and that's just like a Google search. Just look up what it actually, how much you can lose if things go south. Um, what's sort of the timeline in terms of when bad things happen, and you know something you can get into a lawsuit. And just having that basic baseline knowledge is the first place to start off with, right? Just know what the law says and what's there. That's kind of a basic thing. It's very important to start off with. The second thing is there are things you can control and things you cannot control, right? If you're taking care of a patient, there are things that are under your control to a certain extent, like what diagnosis you make, what medications you give. The outcomes, a lot of times, you cannot control. The vast majority of times that you're taking care of a patient, the outcomes are favorable, right? But uh, a minority of times, it's very small minority, the outcomes are that you did not expect, and they're unfavorable outcomes, all right? So the unfavorable outcome happens. Now, out of those very small minority of times when unfavorable outcome happens, an even smaller minority of times would be when the family or the patient would consider going down that route of, you know, a malpractice lawsuit. All right. That's when they're considering it. All right. Okay. So total number of patients you see, small minority of unfavorable outcomes, even small minority in which the patients and family are considering pursuing that route, and an even smaller minority amongst them actually go ahead with it. All right. By that time, things are out of your control. You can't really control it, right? It's happened. And of course, again, these feelings of shame, guilt, you're not a good enough doctor, anxiety, am I going to lose everything? I'm going to be on the street. What am I going to do with my kids? All of this comes in. And that's natural. And it's okay. But just because, it's okay. And anyone who goes through that feels that. Um, so it's very important to have, again, resources, conversations about that. But I also understand it's very hard to have open, honest conversations about something like this just because of the nature of the thing itself, right? So the only thing I have to say is, okay, you know what? Now it's in a territory where it's not in your control, all right? So you just wait. You work with your attorneys if it actually does go down to a lawsuit. It will most likely take several months to few years of your life. It'll become like this little monkey on your back, which is there everywhere you go. But the amount of attention you give to it is in your control. All right. Yes, it's there. It's taken a small part of your life, and there will be conversations. There might be, I don't know, court appearances. There might be a lot of back and forth about a lot of different things. But don't let it overshadow your entire life for the next few months to few years, because what will end up happening is that you're going to lose all that time by giving this thing all your time when it doesn't really deserve as much time as you're giving to it. All right. And the problem with that strategy is that this might not be the last time this has happened, just because of this is just kind of because of the nature of the job itself, right? So let's say you end up giving several months to few years of your life, your complete attention to this, and you get done with it, and you stumble into another one. All right. So what are you going to do then? All right. So compartmentalization is very important. Understanding that, okay, I'm just gonna give it as much attention as it deserves to is important. Knowing what the worst case scenario is very important as well, and that depends on whatever your local state laws are. And then just having the facts in front of you. Um, I don't know if it's a Kansas thing or it's a national thing. Again, you can look it up, but a lot of these lawsuits end up, not criminalizing the team involved. It goes into a settlement. So that's just the fact of the matter. Absolute worst case scenario is, which again is rarely happens. Again, so we talked about the number of patients to see, minority unfavorable outcomes, minority, decide to maybe consider a lawsuit, minority actually do, and even smaller minority of that actually lead up to some kind of a conviction against the whoever is involved. Um, so that's the absolute worst case scenario, and even that absolute worst case scenario, just look at what the law is in your state and see what that would look like. And a lot of those situations, that absolute worst case scenario, objectively speaking, in terms of finances, in terms of your career, might not actually be something that would end at all right? Depending on state to state, state law to state law. So I think that compartmentalization is important. Having that perspective is important. And the only thing you can control in that situation is your response to it. All right. That's kind of all I have to say. So it's very unfortunate when it happens. It can take a big toll on your mental health, your physical health. It can make you feel really bad. But, if you look at the numbers, if you look at it objectively, first of all, the likelihood of this happening very, very frequently is relatively low based on the number of patients you see every day. But even if it happens, at that point, that thing is out of your control, and the only thing you can actually control is your response to it. So just give it enough time, as much as it deserves, and don't let it overshadow your entire life. Just think of it like a monkey on your back which just follows you every day, and you're annoyed by it. You don't want it to be there, but the monkey should not become Godzilla and just take over your entire life.
I think there's some just amazing pearls of wisdom that we got in this last question, and just remembering that it's the matter of when and not if, and just remembering what you can and cannot control, and not giving it all portions of your mind. And I think there's some really great pearls for everyone who's listening. Um, I think this has been a great discussion, and I'm very, very grateful that we were able to talk about this and talk about some things that are not openly discussed, and um, really grateful that they decided to do this with me today. Is there any last words that you have for physicians who are involved in an error that you'd like to say before we finish this up?
I think this has been a great discussion, and congratulations on starting this initiative. The only thing I would say is, get involved. If you're a resident, early career physician, late in your career, mid career, if not a physician, you're an APRN, you're a nurse. Try to get involved with the organization and try to understand these processes, because it just helps broaden your horizon overall, right? And of course, the end goal, the absolute end goal up here, is always delivering the best possible care for your patient. All right. So do everything you can to gather those tools, gather those perspectives, and trying to do that at the end of the day. That's pretty much it. And if you're in an organization that does not have great processes uh, for dealing with medical errors, dealing with safety events, champion one. There are a lot of resources available online. Talk to people about it. Because healthcare can be draining, and I think, at least personally for me, this just helps add a bit more meaning. It just helps inject a bit more zest in the work that I do. It just helps me keep going in day after day after day after day. Because if we're kind of part of something that is leading to betterment in the care that we deliver for our patients, then that's just the fuel that we need to combat moral injury. and anxiety and burnout and emotional distress, because we're actually trying to do something about it. So that's really kind of the only thing I would say. And if that's not something that you are into, that's fine too. Just understand that there are processes there, and the point of the process is eventually to make the care that we deliver to our patients better. And we're all in it as a team. No one, if there's like a just culture at your organization, no one wants to reprimand you. You're really valued. You're very important. um, but things like peer review and mortality reviews, it's just there at the end of the day to make the system better overall.
Yeah, absolutely. And I would just add on to that, for any physician or healthcare provider who's gone through a medical error, um, or has some trauma from it, just believing in the power of self-forgiveness. So forgive yourself, because I know you're probably feeling a lot of shame around it. But the best way to practice self-forgiveness is not to wish that it did not happen, because then you'll keep revisiting what happened, but just to accept it as it happened. Forgive yourself and try to move on, and just remember that time can heal most of these wounds, and learning from it and doing something better for your patient next time is how is something that will help you in the future as well. Um, and thank you, Dr. Rafiq, for joining on this podcast. It was really, really enjoyable, and we learned a lot from it.
Thank you.
We're gonna make this tradition on our podcast to end with a poem, and the poem that I've chosen today is "Instructions of Not Giving Up" by Ada Limon. So I'm gonna read it, and then we're gonna go towards the end. Um, More than the fuchsia panels breaking out of the crab apple tree, more than the neighbor's almost obscene display, cherry limbs shoving, their cotton candy-colored blossoms to the slate sky of spring rain, it's the greening of the trees that really gets to me. When all the shock of the white and taffy, the world's baubles and trinkets leave, the pavement strewn with the confetti of aftermath, the leaves come, patient, plodding, a green skin, growing over whatever winter did to us, a return to the strange idea of continuous living despite the mess of us, the hurt, the empty. Fine then, I'll take it, the tree seems to say, a new slick leaf, unfurling like a fist to an open palm. I'll take it all. Thank you, and we'll see you in the next episode.